Thanks.
Great, thank you very much, and congratulations, and thank you, Michelle, Luis, and Julio, for all the work that you've done on 90-90-90, and I really want to acknowledge UNAIDS, PEPFAR, NIH, WHO, all of you in this room for your support and leadership. I'm going to be sharing with you this morning some data from our ongoing test and treat study called SEARCH, and presenting on behalf of my co-principal investigator, Dr. Moses Kamya, and all those who work in SEARCH in the communities that we work with. I'm going to beg your indulgence. I'm going to talk fast because I want to share a lot of information with you, and I also would like to keep on time. My disclosures are that Gilead Sciences donates Truvada for our SEARCH study. So I wanted to put the trials that you're going to hear about, the next 4 trials, in some context, but I'm going to collapse this slide because Julio summarized it so succinctly. We've known for 10 years, essentially, that ART reduces morbidity, mortality, and transmission. So the question is, what are the questions now? And I would argue that the main question is why we're here today, and the research questions are, can a coordinated strategy of HIV testing, treatment, and services shut down the epidemic? What is the best way to effectively, with a human rights approach, do that most quickly? And what you're going to hear about now is a series of studies that are ongoing that are going to help us hopefully inform the how as a catalytic for our shared goal of making AIDS making it not a public health threat by 2030. Okay, so SEARCH. It is one of the 4 large ongoing randomized test and treat studies. It's fully enrolled, it's got 334,000 people, and it's going into its 3rd year of follow-up. It is testing a multi-disease, population-based, streamlined care strategy of which I will be explaining. So I'm going to briefly give one slide on our study design and then share some results that have not been published on were we able to achieve 90% HIV testing, what does it look like in our intervention arm in terms of getting 90% of people on a population level on anti-retroviral therapy, and then third, what do HIV RNA suppression rates look at in the high CD4 population? This is a population that people argued would never take therapy. They're going to not come to clinic, and because they don't feel sick. So I'll share you what we have observed so far using this strategy. So the key question that we are addressing in SEARCH is, can a population-based ART test and treat strategy shut down new infections? This was modeled by Greenwich and Williams many years ago and predicted that we could do this. And secondly, we are looking at what are the additional gains. Julio and others have remarked on these already. What is the key question? SEARCH is an implementation science study. The question is, what is the best way to do it? And then, of course, what would it cost? And importantly, and there's going to be a special session on this on Tuesday at this meeting, talking about the power of the HIV movement to catalyze progress in the response to other non-communicable diseases. So in our study design from the get-go, we had put forth the question, can efficient HIV chronic care models be adapted to establish care for other chronic diseases such as diabetes and hypertension? This particular study is being conducted in rural areas in East Africa, one site in western Uganda, one site in eastern Uganda, and sites around Lake Victoria in what was formerly called the Nyanza province, around Homa Bay and Suba. The study design for SEARCH is a cluster randomized study of 32 communities. They're pair matched, and the communities are an approximate size of 10,000 each. Our intervention communities receive the SEARCH package, which I'll describe, and then the standard of care communities receive the evolving and excitingly evolving standard of care for that country. Our primary endpoint is a direct measure of new HIV infections, and we're looking at secondary endpoints. I won't list them all, of all the ones we know are important for community health, and then importantly also community productivity and costs, such as workforce participation, child labor, prevalence, agricultural output. We know all these things can be positively influenced by the scale-up of antiretroviral therapy. So in terms of our intervention strategy, what I've done in the slide here is put it into the context of 90-90-90. So what we have first is the search strategy for testing is we do annual community health campaigns, which I'll describe, and household testing using a multi-disease approach, and then we do additional testing of key populations. In terms of achieving the goal of 90% of people on anti-retroviral therapy, we do rapid linkage, same-day ART start when possible, access to providers, and what we call tiered tracking and feedback for those individuals who miss their appointments. In terms of retaining and suppressing patients to accelerate that, we have a chronic disease-centric model of care. So when people come to clinic, it's people with many different diseases receiving care. It's patient-centered, good access to providers, and what we call streamlined care, which is longer intervals between visits, and an intervention that we developed which is called viral load counseling. Okay, so now what I want to do is share with you the data that we have about the question, were we able to achieve on a population level 90% coverage of HIV testing? So that was our goal, to determine HIV serostatus of 90% of adult residents, and also to do testing, linkage, and ART start all within a short time period, what we're calling collapsing the traditional HIV treatment cascade. So the way we approached this is very community-based. We met with the communities. We talked about, this is many years ago, saying, how do you think we could possibly achieve coverage over the course of the community? What do you think about community campaigns? They really liked the idea of the community campaigns, but they said to us, we want more than just HIV. So we talked about services that we could offer. We came up with a core package that included hypertension, easy to measure blood pressure, diabetes, easy to measure blood glucose, and also some really simple public health services such as rapid testing of malaria, treatment on site, offering bed nets. So this was very community-based and community-owned. We performed a census. We conducted these community health campaigns. And you can see an advertisement here on the slide of the different services that we were offering, the multiple diseases. For people who didn't attend the campaign, we went to their homes and then offered these services. And then, of course, people who at the campaign were found to have diseases, there were representatives from the clinic there to meet and greet the patients and accelerate their access to starting therapy. So these are, I think, the visuals. I wish you could all see one of these. Hopefully sometime you can. These are some of the visuals of the community health campaigns. The pictures with the wedding tents are from Uganda. We see about 1,000 people a day. People come sequentially through the tents. They're meted and greeted. There's health talks, agricultural talks when people come. It's not just about saying HIV testing. It's saying, what can we do for the health of the community? Topics about nutrition. We meet the community where they're at. Here you can see there's a campaign on the shores of Lake Victoria. We also talk to the community. We do night campaigns because many of the people, the fishermen, for example, that works better with their hours. And you can see some of the geographic settings are very, very difficult. We do deworming for children, malaria testing and treatment. This all happens with a rapid throughput at the campaign, and the community is at the front of this. It's not the researchers, it is the community. So, what are the results? We presented these earlier at CROI this year. Among stable adult residents in this large study, which we defined as living in the geographic area, the community, at least 50% of the year, we were able to achieve HIV testing status on 90% of the stable adult residents. Now, everyone knows in this room that healthcare for men has really been a challenge. Just no matter what disease you look at, men are less apt to access health services. So this is broken down here by gender. We weren't able to achieve 90% of the men, but 88% of the men, pretty close, and 92% of the women. I'm happy to talk to anyone after the meeting or on the break. We did a whole series of events to mobilize men and to appeal to things that men we thought would want to do in terms of a health campaign. One of the questions is, so this was a hybrid approach. First it was a campaign and people didn't come to the campaign, we went to their households. It turned out, of the whole population, 80% we tested at the campaign, and then 20% we did in subsequent home-based visits. So as Julio said, 90% is not enough, we're always going for 100%, so we have to ask ourselves, who did we miss? So in the initial analysis that we've done about people who have not tested in the first year, young men, not surprisingly, were the ones that were least likely to test, interesting. Higher education was associated with less testing, and also people who lived in the community at least 6 months but traveled more outside of the community. Okay, now I want to go to, that is our achieving 90% of testing. Well, what about achieving 90% starting anti-retroviral therapy? One of the things when we think about scaling up, if we just keep doing business as usual, I think we're going to have a problem reaching our goals in the fashion that Michelle has told us to do. Because we're going to be bringing in many people with high T cell. They're busy people. They don't want to be in clinic. So we have to change the model of care. And that's what we did from the get-go in SEARCH, was we developed this streamlined model of care. For the purposes of time, I'm not going to go through all the things that we did. These are not high-cost things. What we do is we use our resources sparingly to get most of the people in, and then we use the extra resources that we have to get people to come in to achieve. My third thing that I wanted to talk to you about, I think I have a minute and a half left, is what do our viral suppression rates look like in people with high CD4 cell counts? So in conclusion, using a hybrid HIV testing approach with community partnerships and mobilization, testing 90% of a rural East Africa stable residents is feasible. Our costing and community-led models are under study. Secondly, streamlined care in a chronic disease model can be implemented in a public health setting. This was all done with partnership with the government in the context of the existing public health setting. Our qualitative studies revealed a high level of enthusiasm for the multiple disease approach, normalizing HIV with other diseases. And early results, as you saw, reveal high uptake of ART and viral load suppression. I want to caution, as a scientist, there are absolutely no conclusions we can make from this. This is an ongoing study, but longer-term follow-up, costing, and comparison are ongoing and will help inform these questions, and also our bigger question of how much can this further reduce reduction of new HIV infections. So thank you.